for me, there's two sets of 3 golden rules. When it comes to the approach to cancer patients, I'm going to say okay, I'm now going to talk imagining money's no option. Yes, I work in a referral practice, I'm a little ivory tower, but I think there's some principles here that wherever possible we should try to follow, particularly if we want to do cancer care properly. Number one is we need to know what we're dealing with. We need to know what the tumour is, and where possible we need to know, is it something to worry about? So, we need to know if it's potentially malignant, how far has the disease got, and thirdly, we need to know if there are any complications. So do we have a paraneoplastic syndrome? Have we got a hypercalcemia that's may drive renal failure? Have we got an immune-mediated hemolytic anemia, or worrying if you're going to cut the dog, a thrombocytopenia? Okay, you do not want to be doing a splenectomy in a dog with platelet count 15. That causes most of us to get very, very stressed. In terms of the approach to tumour patient when we're managing it, it's very simple. Don't let them starve, don't let them feel sick, don't let it hurt. Now, there are 3 sort of things very basic things I talk to friends about this all the time. So what I'm going to say with diagnosis, because if we want to know why do we know diagnosis, we don't know what it is. Can we treat it? Should we treat it? I think when we talk about the leukemias, some point, probably just after lunch, there's some of the leukemic disease family that we absolutely should be treating because they have great outcomes. We could do an awful lot. There's some, like acute myeloid leukemia, where we should really put in the kettle on and say, do you want the ashes back in a casket or a scatter box? Because there's probably no point at all unless even trying. Okay. So knowing exactly what you're dealing with helps us be the best clinician, put that welfare of the animal first, and make the honest decision what's the right thing to do. So, now, this, I've got the side off next may cause controversy. So wherever possible, I think we should get samples. Now, I'm probably preaching the converted because you're on an onco course. But I think the days of, do you want me to send it off or should I just chuck it in the bin? That conversation's probably gone. Because I'd actually challenge it ethically. Just because you have an MRCVS, I'm being deliberately controversial here, so if I offend anyone, I apologise, but our MRCVS is a licence to cut. It's not a right to cut just for the hell of it. And if you're going to take a scalpel to a dog, shouldn't we know why we've done it? Personal opinion, just with our clients as they are, okay. And so we should really try to get it. We could get answered with an FNA. I'm going to go through how we do FNAs in a second. I don't want me to suck eggs, but I think there is a right and wrong way of doing FNAs. You get an FNA with DiffQuick, it'll actually cost you and I £1.50. 5 microscope slides, 5 ml syringe and a green needle. It's not going to cost much to try to get an answer. We can look at fluids, we can use cytology. We don't have to do histo necessarily, but wherever possible, get the sample. The only time where we wouldn't do that is where knowledge of the disease is not going to change what you do. Now, what I mean by that is, your classic Friday night, particularly with your new grad, when you've said, I'll be on call and support you, and then you think, oh shit, why did I say that? German Shepherd, Friday night, acute onset collapse, palpable fluid thrill, and a splenic mass. You put your ultrasound probe on, you can see a deformed spleen with nodular capsular deformation and fluid in the abdomen. The chance of that not being a splenic hemangio is very small, but the spleen's bleeding, so you've got to take the damn thing out, whether it's a hematoma or hemangio anyway. So I'm not going to do the biopsy then and then have the dog back. We're going to take it out, but I'd still think about sending it off. So I think there are 1 or 2 times when we wouldn't do it. So, and I know this is very easy for me to say this, but I think wherever possible we shouldn't give owners an option over histo. Even if you stick the sample in formalin and find a place at the back of a cupboard. Because if the tumour, if the owner comes back in and says, you did that lovely surgery 6 months ago, well, there's a bit of a swelling in where you did the surgery. You can go, oh, flip, sorry about that, I can work out what it was because I've still got the sample. And yes, things degenerate when they're in formalin, I accept that, but you've got an opportunity. And again, all of us with our practice manager hat on, pre-anaesthetic blood screens make large amounts of profit. But actually, if you do a really good history, a really good exam, and a PCV, do we really need that? I'd rather spend the money on histo if it's a tumour case. So I'm being controversial, I want to stimulate some thought, okay? And I'm not going to tell you any practices because we will have people to pay. I've now got 295 people to pay, which is getting ridiculously scary. So I'm all in favour, but I think wherever possible, if you've got a motivated client, try to get a diagnosis. Because if we just take a lump off, it's almost cosmetic surgery. And if I've offended anyone, let's just see if we can get there. So, how can you get biopsies? We can do FNAs, we can do punch, we can do grabs, all these sort of things. So, definitive diagnosis with the exception of lymphomas. The only thing we don't do histo for lymphoma at all, we just do an FNA.